Patrick Mahomes, Micah Parsons, blown out ACL. What's going on? Let's dig in. I'm Doc Faisal, orthopedic surgeon with Move Smarter Health. We are sponsored by an educational grant from Kinesi Movement. I love sports. I love talking about injuries. I take care of shoulder and knee injuries, and I operate and treat on them. And please consider this an educational, informative video only. Here we go. So what happens? What are the there's so many different mechanisms of ACL tear. We know that, right? I've explained that to you before. Mahomes, it was his left knee, right? Landed, pivot shift, varus, alignment, boom. For Parsons, it was his left knee. Left knee. Mine, it was my left knee. Oh, look at this. I'm already connected to these two top athletes because I was a top athlete in recreational soccer on the field in San Francisco in 2004. Yeah, that's it. No, it wasn't varsity. No, it wasn't a pro team. It was a recreational league in San Francisco. Yeah, that's how competitive I am. So, boom, he lands. All right, one goes varus, one goes valgus, okay? There's obviously mirror image, opposite knee. This is a right leg because I think I lost his other leg.
They gotta be expensive too, right?
They are. Legs are not cheap, right? Think of it, it's 1/4 your body. Yeah, it's not your brain, but it's still 1/4 your body. So mechanisms are slightly different, but there's so many different mechanisms for your ACL. In the end, no matter what, when they planted, they were slightly flexed, okay? Non-contact, keep in mind, all right? One goes into valgus, which was Parsons. He was like outstretched. Again, think of this as a mirror image. Outstretched, and he went like this, and it kind of pivot shifted on him. And you could see, because then his leg, it was almost like the foot was backwards by the time. So he pivot, landed, boom, and went out. In the case of Mahomes, again, mirror image, he goes in and he lands with more of a varus alignment, and then he pops out. Okay, so, thanks, Charles. You've been great. Sorry about the nails, took a while. Now, your knee. You can go in different alignments. You can pop it out. What is the most important feature, the most important thing that I talk about when it comes to ACL injuries? It's not about recovery. It's not about the type of reconstruction. Yes, I heard it out there. Long-term consequences of cartilage. Right. So what happens? ACL, boom, pops out, right? Well, okay. Not quite like this, That happened in the other guy. So as far as we know, isolated ACL tear for Mahomes, okay? And in that particular situation, the ACL rips, but what happens? We have a subluxation and a pop. The pop is, you got it, chondral impact. So the impact, I'm just gonna remove the cartilage out of the way, the meniscus. It's wrapped by cartilage, like the cartilage on the end of, the gristle on the end of chicken bones, right? So you have a smooth cartilage, hyaline cartilage. Then you have this other fibrocartilage structure, which is the meniscus, right? Which has hoop stresses, you know that. When you pop it out, yes, that's that is the pop of an ACL tear, right? Cut that out.
Cut that out. I'm leaving that in. Crazy. Just have drums on those.
So that's the pop of an ACL. When you hear that, it's not the fibers tearing, and I experienced that myself in my incredibly athletic career. So anyway, pop the ACL. But when it happened, I was cold. I was on the sidelines because I had just played for a solid 30 minutes. I took a break. We were down by, I think, 2 or 3 goals. And I said, okay, I got to go in and help the team. And I go in and I'm backing up, about to twist and turn for a ball that the forward left wing offense kicked towards my direction. And I actually remember pivot shifting, and it was a varus plant alignment pop. And I could feel the fibers. Like I later, the memory is there. It's not PTSD. The memory is there where I could feel something ripping, and that was brutal. Yeah. So when that happens, your ACL goes out, the cartilage impacts, and what's the easiest part of an ACL tear today? The surgery. If it's isolated ACL tear, we all know what surgery to do. Now, that doesn't mean it's the optimal surgery. Okay, it is what we know right now from a scientific academic scrutiny of all evidence-based data in terms of ACL reconstruction, making bone tunnels, reconstructing with a ligament, autograft, allograft, stabilizing it, and getting the player back onto the field within 6 to 12 months, 6 months accelerated rehab. So he gets the surgery right away. Like, I think it was last night, right? Yeah. He got the surgery, and it was done by a Texan. So he is playing in Kansas City against the Chargers, flies out to Texas, gets his surgery by the Dallas team doc. Now, he has a relationship with the team doc. He's had surgery for his LCL before, and so he trusts this surgeon. And we've talked about this in another video. Surgeon, patient, confidentiality, trust, okay? Educational video, context of Mahomes surgery. I don't know any more than you know in terms of all the medical information that's released. And so we're talking about his injury, but it goes to show you that you don't always necessarily have your surgery by the team physician for your team. Okay? So he went to someone he knows before, he's trusted before, and has an expertise that he prefers, and that is patient choice. You can go where you want. Sometimes we're forced to do that based on our insurance, payer, provider, network connections, in-network, out-of-network, co-pays, deductibles, all of those things, which really make it difficult for us as physicians and patients to have that perfectly commingled, established patient-physician relationship. However, that's where he went. He had his surgery. So the easiest part is just doing the reconstruction. Now, we don't know if his meniscus was damaged, how much cartilage was injured. We know that more often than not, you get bone edema following an ACL from that chondral impact, right? So the chondral impact causes some type of cartilage which may be not necessarily present as acute, subacute, but chronically it can result in changes over time. And so the extent of that cartilage is a long determinant for his longer recovery. However, acutely, we know that he will be back in the game soon, within 6 to 9 months, hopefully 6 months. So he's back for training season. I don't have a crystal ball. Did you say 6 to 7 months or 6 to 9 months?
Preferably 6.
Don't say it. 9 months. Okay. So 6 to 9 months, hopefully 6 months, right? So he comes back in the game, but most athletes, super athletes, power athletes, Olympic athletes, pro athletes. A lot of the data that's been referenced was from the hockey players. Pro NHL players feel confident in their knee 2 years after their ACL reconstruction. So we know that. Is it for football players? More than likely, you know? It's a good balance. And why is that? You got it. Proprioception, recovery, rehabilitation, and trust. It's that mental mind-body connection that you trust your knee again and it starts to feel normal. Now, let's assume he doesn't have meniscus or cartilage. Well, no, like gross cartilage injury. And when I say gross, that means a significant disruption of the cartilage. I don't mean that it's gross, like a, you know,
Ew.
ew, right? I mean, there's, you know, minor, there's gross, macroscopic, and I'm talking about the gross macroscopic concept of gross. So we use that a lot in, you know, medical jargon, as it were. You know, we use gross all the time, but not in the same gross that someone, you know, would necessarily use that in the public sense of the word gross, right? And I'll give you an example. Like we can say that, oh, his knee was grossly intact, but he had a minor contusion of the knee, right? In this case, He was grossly unstable because his ACL was torn based on the Lockman or instability testing and had to have reconstruction, but he had no gross cartilage injury on arthroscopy or MRI other than a bone edema or contusion. So that's the kind of way that sometimes you would describe an injury. Now, I'm not saying that that's the case with Patrick Mahomes. What I'm saying is that's how you could describe the term gross in various contexts in order to understand it. Okay, so no, I'm not AI. I may look like AI, but I'm not an AI.
So is him having surgery the next day, that's good because it means there's no swelling?
So it's a good question. Like, do you have surgery right away or do you wait? Now, the rule of thumb is if you don't have more than 90 degrees of motion, you don't want to do the surgery right away because the swelling affects your recovery. You have the hematoma. The hematoma is good because it throws in your own regenerative factors in your own body. But initially, you have a lot of inflammatory tissue, and that inflammation can affect how you do the surgery. But primarily, it affects the stiffness, recovery, rehab, and the formation of scar tissue, which there's various medical terminology for that we won't get into, but you get this sort of scar ball of tissue that can form. Sure, you can, I'll tell you, because you're gonna love the term, it's called a cyclops lesion. Okay, get past that. So you can get this stiffness and scar tissue that's forming, and that can affect your recovery and rehabilitation. So traditionally, it's not about waiting a week, waiting 2 weeks, waiting 6 weeks after the surgery. It's about having your range of motion and the swelling down so that you can have a good functional recovery. However, if you say he did have a meniscus tear, and say he did have another associated ligament injury, and you do it within 48 hours before you really get that stiffness, and his motion is more than 90 degrees, you want to be more than 100 degrees ideally, but you get at least the 90 degrees of motion, then doing the surgery right away does not necessarily impact it long term. You're also compressing the time frame from surgery to reconstruction. And there's data that people have tried to study early versus late. Most of the data long term showed late reconstruction is better, but that again, you have to quantify by the various, numerous variables, the stiffness, range of motion, swelling, hematoma, articulation, as well as the overall associated anatomical injuries. Now, assuming isolated ACL and he has good motion and swelling is gone, then more than likely you can go ahead and reconstruct him right away and proceed with surgery. And the outcomes based on the evidence in the literature say that he should have no different outcome than if you were to have waited than if you did it early, as long as he has the motion and the swelling is not necessarily limiting his range of motion.
Do you think the Cowboys team doctor owes it to the Cowboys to not do a good job on his surgery?
Yeah, that's an ethical question. And, you know, the obvious question is that a physician treats a patient. He treats the patient like he would any other treatment. And just keep in mind that famous team docs, they treat everyone across. Like, so if Patrick Mahomes went to this guy must be good. He must have a reputation, or there's a trust factor. So clearly, he's going to do the best job because, one, he's a physician. He's taken the Hippocratic Oath. His principles of medical training teach him and train him to do the best for the patient. Because you have to put the team aside. When you're a physician, the team is irrelevant. Now, the coaches, the team, whoever they are, the organizational structure will try and influence or wish otherwise, and they're not going to try and influence. That would be unethical as well. But ultimately, you know, the only people that take the Hippocratic Oath are physicians. The true Hippocratic Oath are physicians. Now, there are variations for it in various medical professions, but originally, the Hippocratic Oath, you know, the coach isn't taking a Hippocratic Oath to do no harm to a patient. The trainer isn't. Certainly the owner of the team isn't. So the only person who has the best interests of that patient in mind, assuming they are rational, have followed the Hippocratic Oath and the principles and practice of orthopedic medicine and surgery, is going to be between the physician and the patient. And that trust is key. And if that guy's, doesn't do a good job or tries otherwise to make it less than perfect, I mean, that would be unethical, and he's just ruined his reputation. So certainly, I highly doubt, or I can probably say no for a fact, that it's unlikely that this, even though he's the team doctor for another team, he's not going to botch up Mahomes' knee just because he's the team doc for Dallas Cowboys. And you see that a lot. Like, not all the Niners go to the Stanford team doc for their treatment. Not all the Cowboys go to the Cowboys team doc. Not all the world top surfers go to their local doc. They'll fly and get it done. I mean, we saw that with NHL Toronto Maple Leafs player Austin Matthews, right? There was this big controversy. Where'd he go? He went to Europe to get some treatment. Did he get regenerative technology? Did he get surgery? Did he get an evaluation? He went to whom he thought was the top guy for whatever specialty he needed and got treatment there. Okay, so it doesn't matter. You can go anywhere in the world. You're a top athlete. If insurance doesn't matter, you can go anywhere in the world you want to get your treatment, as long as you go to a licensed, practitioner, physician, who's trained in the arts. Like, you don't want to go see a chiropractor for your knee surgery, right? You don't want to get an opinion from a physical therapist on whether or not to or how to reconstruct your ACL, right? It's outside of their scope. People give plenty of opinions. Like, you'll get a physical therapist, a chiropractor, a nurse, a therapist, and then you'll get your armchair quarterbacks that'll have an opinion. Everyone can have an opinion, but the opinion you trust is from the person whose scope of practice it is to do that treatment or procedure or surgery. And sometimes you see that, and patients will come confused, right? Patients will show up saying, yeah, but my therapist said, or my chiropractor. It's like, if you're not the one cutting the patient and doing the surgery with the training and expertise and the scientific, academic, evidence-based scrutiny of literature that you have read and trained upon, then you don't really have the right or the scope of practice medical legally to give any other opinion that within your scope of practice. You'll see that with insurance adjusters and insurance companies. They'll give all sorts of opinions, but they have no idea what they're talking about, even if they think they've read a paper or have a sense of understanding, and it's medical legally a liability. So, if you have a problem that needs surgery, go to your surgeon. That's ultimately the goal. And so, Patrick Mahomes goes to the Dallas Cowboys team doc because he trusts him. He must be a good surgeon, and he has a good reputation, and so that's how it happens. And so, Mahomes, I hope you have a great recovery because you're the best quarterback right now. Well, maybe not this season. However, you better come back because I want to see you kick some ass. Oops, can we say that?
I think so.
Oh, okay.
Yeah, this is not for kids anymore, though.
There you go. Well, just blurt that out. Maybe make me a cartoon and just say arse. Arse. I'll just say arse.
You can say anything.
I can say anything as a cartoon. Yeah, let's just use arse. Arse is just a little better. Okay. So in Micah Parsons' case, so he had an ACL tear as well, right? So big injury. And actually the Green Bay Packers were doing pretty good. Are they going to do as good without him? I don't know. Let's find out. So Micah Parsons, his injury was slightly different. Same ACL tear. Now again, this is contextual education about this ACL tear, about this knee injury. ACL tear, I just gave it away. I just told everyone it's an ACL tear. Darn it. I don't think anyone knew it was an ACL tear before I just told them. All right, so he has this injury, ACL tear. As far as we know, it's an isolated ACL tear. He has not had surgery as far as I'm aware yet. Now, his ACL tear. Now, what's going on with ACL tears? It's becoming more common, top performing, high level athletes. What is going on? Like, I mean, these athletes are super athletes, so they're pushing their envelope of activity. So yeah, they're at risk of injury. But, I would sort of sit back and say, wait, we have had 30,000 studies on the ACL tear, and we still don't have a solution. 30,000 studies in 50 years on the ACL, and this still keeps happening. Is it nutritional? Is it biomechanical? Is it biologic? Is it anatomical? I mean, there's so many variables out there. Is it the way we move? Is it the way we run? Is it the turf? Is it the shoe? Is it the clothing? Is it just the preparation? Is it the way we train? Is it the engagement, activity of everything that we do for athletic prowess? Great question. We don't have the answer to that yet. Okay. Was that dramatic?
It was good.
It was good. So the mechanism of injury, we talked about Patrick Mahomes before. So mechanism of injury, it is an ACL tear. With Patrick Mahomes, it was a bit more of a flex varus non-contact pivot shift ACL tear. In Parsons, it was his leg was outstretched in a more valgus position, and then he twists it in. So the mechanism, slightly different. Like, you can have so many different mechanisms. You know, I know for a fact that in various textbooks, they will describe there's at least 6 to 12 mechanisms of ACL tear, just like there's, 6 to 10 PCL mechanisms of injury. However, we have to look at the knee as a global limb in a three-dimensional structure. We try and isolate it biomechanically because we do a lot of cadaveric sectioning and studies to understand how these tears happen. So we try and linearize our knowledge, right? It was varus, valgus, force, adduction, component, flexion, this alignment, this vector, all sorts of different directions. But we need to look at it a little bit more from a three-dimensional construct in terms of trying to understand it, and not necessarily get siloed into saying that, well, in order to prevent ACL injuries, you have to reduce your moment arm in this position and train in this manner. Some of it's helped. We see that in women's soccer, but yeah, exactly. Injuries keep happening.
Does it matter how you pop the ACL? I mean, is it worse to go in versus out?
Yeah. So, it's a good question about, is there certain mechanisms that are worse? I think the most important thing is that the associated injuries. If you have an isolated tear, more than likely it won't necessarily matter the type of mechanism that leads to the ACL tear. But more often than not, the extent of the chondral impact and the chondral injury, whether you have an associated LCL, MCL, posterolateral corner, posteromedial, anterolateral, associated fractures, meniscus, associated minor ligaments, associated PCL tear, patellar tendon, quadriceps tendon, and the whole arc of mobility being affected. I think those are the important factors in terms of, which mechanism is worse ultimately. Like, one could argue that there's literature suggestions of one versus the other. However, ultimately, an isolated ACL tear right now, based on our current knowledge, is treated similarly no matter what the mechanism of injury is. Now, the rehab may be different. Like, for example, if you had an ACL tear and say you had a hamstring autograft instead of a patellar tendon or quadriceps, then your rehab, you might more focus on hamstring stretching, strengthening, recovery, quadriceps, patellar tendon, all of those things in terms of your range of motion and mobility, in terms of avoiding scar tissues, adhesions, and all of that. But we do know that if you're a NCAA Division I rower and you have an ACL tear and you get a hamstring autograft, you will recover because within 6 weeks, your hamstrings are going to be about 95% of your strength. Now, those studies are published, and there have been more studies since then. However, the important factor is we are not NCAA Division I or pro athletes. So how is that different for us as the regular Joe? Well, I'm not Joe. You're Joe. Why did I call myself Joe? Wait, I'm transformed again. Ah! Okay, so back to myself. So basically what it matters is how you do your recovery, how we do the evidence, and the literature is all based on lab, clinical data, in studies, and within this evidence-based construct. However, what happens in the real world with everyday people like me and you that are getting injuries, and does it matter whether we use autograft, allograft, or hamstring versus patellar tendon? Most of the data is not on you. What's your ethno-demographic, socioeconomic status with insurance and provider, depending on which surgeon you choose? compared to the top super athlete who has a physical therapist, trainer, coach, and ice bath and regenerative technology available to him every single hour of every single day. Big difference, right? So your access to healthcare is completely different and can offend your it can offend your outcome, but it can affect your outcome as well. Now, Micah Parsons, top athlete. Green Bay Packers, will they do well? I don't know. Will he recover? Yes. When did he have surgery?
I'm just looking right now.
Okay.
It doesn't look like he's had it.
Okay. So depending on when he has surgery, you're talking, again, 6 to 9 to 12 months. It all depends on his recovery and his rehab and the type of reconstruction can matter. You know, back in the day when the whole concept of accelerated rehab really came out was Dr. Shelburne, Indianapolis Colts, 6 months open. He didn't open quadriceps, patellar tendon, bone, reconstruction, and got these athletes back in the game at 6 months. Now, we're doing it arthroscopic for the most part. We're doing it with various different alternatives of technology. Where is it hamstring? Is it bone tendon bone autograft? Or is it quadriceps tendon autograft? Lots of different types of technology out there. Lots of different types of implants, autograft. There's more options with allograft as well. Now we can get pre-shaped bone tendon bone that we can use. What's my favorite right now? Achilles bone tendon pre-shape. So I can dock it, secure it, and it's a solid graft. It has great function and strength. And if you're not an NCAA Division I athlete or pro athlete or semi-pro athlete, and you're under 25 or under 30, and you're more of a recreational athlete, the advantages of autograft versus allograft are not so distinct in terms of re-rupture rates. And therefore, again, you talk to your patient, you talk to your family, you talk to your physician, get another opinion, but ultimately it's your choice. But I often find for the older recreational athlete, it doesn't make a difference, and my preference is to go with the Achilles bone tendon allograft, but that can vary. It all depends on the conversation. Some patients prefer autograft no matter what. They don't want to take the risk of any type of infection or tissue or someone else's tissue from the tissue bank for their body. You know, and so everything varies. Everything is different, and it's your patient choice that matters.
So his position is much more. Explosion is much more necessary in his position. Speed and explosion, and Mahomes doesn't have to. Like, he's been kind of ginger on his knee this year, anyways.
Right.
Parsons has to be
explosive.
So like, I know it's technically 6 months.
Yeah.
But does it push it back a little more because of the type of position?
Absolutely. Not only is the sport matter, like if you're playing air hockey, your ACL may not be as important, right? Is there professional air hockey?
Probably.
There probably is professional air hockey.
Pickleball, I'm sure
there's hey, don't.
It's fun.
Pickleball is fun, but yeah, there is pro pickleball, right? Okay. So, but yeah, you can be position specific and sport specific, and that's again the beauty of the real world kinematics of kinesi. It will really help elucidate those differentials. I mean, there are so many different factors in terms of your recovery and activity for various sports and sport-specific training. And certainly there is, but certainly I would agree that the defensive end linebacker, where he's required to be suddenly sprint, explosive, and sudden movements, versus the quarterback who is protected, but he may still require having to be explosive, but he doesn't have to charge in and suddenly lunge at a quarterback or another player. He has to avoid them and walk away or step away. Slightly different. He still has to have good strength in his legs. So if you were to ask me in general, can a quarterback come back to the game sooner than an athlete like Micah Parsons in his position? It's possible. And I would probably say yes, because you have more strength, rehab, and recovery required, because the type of confidence you need to have that sudden explosive power may be a little bit more demanding for someone like Micah Parsons versus someone like Patrick Mahomes, who may be able to get back in the game sooner. Now, Micah Parsons, super athlete, Patrick Mahomes, super athlete, they could be both back by 6 months, right? But Could Patrick Mahomes get back in the game when he's like 85 or 90%? And how does that compare to Micah Parsons? Does Micah Parsons have to be 90 to 95%? Well, that's a great question, you know? Like, if we had a Kinesi score on these individuals, then we could say, yeah, in order to get back for this position, for this sport, in this time frame, you have to achieve a Kinesi score of a certain number in order to get there. Yeah, that would make things so much simpler. We don't have that right now. We're working on it. However, between the two, there is more likely, again, it's a legalese term, right? More likely than not. It's more likely than not that Micah Parsons may require a longer, more aggressive, more protracted rehabilitation program to get him as explosive as he needs to be back in the game compared to Patrick Mahomes. Yes, you're right. Questions?
Hey, for the people that go to Europe and go to like Germany for treatment, is it stuff that's you can't do in America, or is it stuff that just they're more cutting edge than they are in America?
It depends. So the question really is, why do some people go to Europe and not? Well, there's a difference between how FDA regulates medical implants, devices, and treatment, and how the European agency addresses certain things. So things can be FDA approved or labeled or registered or authorized as opposed to CE marked. So if something is allowed in Europe and not in the US, it doesn't mean something is better over there. There may be different treatments available over there than here. Now, I worked in the FDA for a couple of years, specifically in medical device and regenerative technology and combination products and even drug device combination products. And so what we did see is that the scrutiny as a physician, orthopedic surgeon reviewing data, there were some things that I and the team and the entire FDA was not comfortable with authorizing or approving or labeling in the US for particular disorders. Now, that doesn't mean that the European agency was, didn't have the same scrutiny. They just made different decisions. They had different opinions. Now, we can see that some people believe, oh, well, this is available in Europe and not here. And some people say that the bar of regulation is different. Well, of course, the bar of regulation is different. We can say that, hey, we are more critical of data and science in the US than in Europe. We could argue that, but I was on the FDA on the inside. Now, before the FDA, I always said, oh man, why can't we do this in the US? Then you go inside the FDA and you have access to proprietary data that no one else in the world can see other than the FDA. And then you realize, okay, I would not put this in my patient. And so from my perspective, in my isolated N of 1 experience with the FDA for those 2 years, I felt comfortable that the decision making we were going through was scientifically accurate, evidence-based, and could hold up to any scrutiny. And it felt comfortable making decisions on anything that was approved or authorized. Now, because we had the best available evidence. We had data that was never published. Some data that was published, but then some data that will never see the light of day. It was proprietary industry data. And so it's protected. I can't ever discuss it, ever. But in general, I know that there was data with certain companies that I reviewed and made decisions based on that. And so, and for example, regenerative technology, all sorts of various, progenitors that may not be available here, and certain treatments where stem cells and others, even certain implants are available in Europe. But it could also be that some people go to Europe just because they just want a different opinion. Like, for example, a lot of hockey players, even some basketball players, they'll play overseas, right? Soccer players, basketball, I think it's a lot more, right, than it used to be. So they may have come across, and their colleagues, say from Sweden, Switzerland, Germany, Russia, whatever the team is, may have had treatment, and athletes talk, and they say, oh, you should go see Dr. So-and-so. Dr. X is amazing, and you should get an opinion. Because you get your opinions from the Canadian docs, the US docs, but hey, if you want like a globally satisfying opinion, my ultimate recommendation to any patients is, if you're not sure what you want to do, that's your choice as a patient. You need to decide. And if you're not comfortable with my opinion, get 3 minimum, right? My opinion is one of hundreds of thousands, right, in the world. You get another opinion. You get at least 3 opinions and you pick one. You could get 4, you could get 5, you could get 10 opinions. Nothing wrong with that. You know, like the idea that, oh, he's doctor shopping. It's okay. You know, there has to be this understanding and trust between patient and physician. And if that doesn't exist, and even if it does exist, it's like, I trust him, but I just want more information because they don't do this type of treatment here. So I'm gonna go to Europe where they do that treatment, and they also do what Dr. Mirza does, but Dr. Mirza can't do that regenerative technology or stem cell, so I need to get another opinion, and that's perfectly fine. That's how you as a patient can make an evidence-based decision that you're comfortable with, because you need to look at all the risks and benefits. If you understand the risks and you say, I do need surgery, but I'm not sure what type, should I augment it in a different manner with an implant or a regenerative technology, for example, that's available in Europe? Let me find out. And if you have the wherewithal and the funds to go to Europe or go elsewhere and get another opinion, great. Sometimes insurance companies will authorize other opinions within the US framework. I've had, friends that got opinions at the Mayo or other places, and sometimes insurance will authorize it, sometimes they won't, but it's always good to have that opinion. And not even an insurance company can force you to have treatment dictated by one treatment provider. You are allowed, just from an ethical, let's forget about insurance companies, because, I think that really muddles the picture of healthcare when you bring insurance companies into the framework, because you as a patient want to get your best opinion. If you want to know where the best apples for your apple pie is, you're going to talk to people that all over the country about apples, different types of apples and apple pies, and go visit. Like if you're a foodie, you're going to check out all the restaurants for chili, for, one of my favorites right for a while there is bread pudding. Oh my God. I always thought about just, Carmel. It's a little town nearby. People have probably heard of it, right? So, of course they've heard of it. So in Carmel, there's a bunch of restaurants that have bread pudding. And so friends of mine, talked about just going around doing like bread pudding hopping, not bar hopping, but just restaurant hopping and checking out the bread pudding. And it became really popular. I think in the last 10 years, everyone started having bread pudding. But bread pudding and caramel brulee, like a good creme brulee, are my favorite desserts. So why am I talking about food? Because I'm hungry. So let's wrap this up. So if you want bread pudding and creme brulee, go to Carmel. Well, there's lots of places. Carmel is just one of them. It's close by, but a lot of places have really good creme brulee. I will say that the Ahwahnee Hotel in Yosemite has an incredible creme brulee. Their caramel apple cheesecake was pretty good, but if you ever go there and you just want to splurge on dinner or even just dessert, just go to the Ahwahnee just for that. Well, they have other things, but it's kind of pretty. But their dessert chef is very good. So get their creme brulee. All right, so we're talking about ACLs, not dessert. So your dessert is seeing Patrick Mahomes come back on the field as a better, stronger superstar than he already is. All right.